Assalamu alaikum, students.
Walaikum salam.
Okay, we'll go directly to the lecture. So today's anatomy lecture will be about the oral cavity, the pharynx, and the esophagus. So these are the three topics we'll cover in this lecture. Okay, coming to the objectives, these are the objectives for us. Describe the anatomy of the oral cavity and its details like boundaries, parts, and supply. Describe the anatomy of the palate, then anatomy of the tongue, as well as the pharynx and the esophagus. Okay, so we'll go directly to the oral cavity. So this is the oral cavity. Okay, so this oral cavity of the mouth extends from the lips to the oropharynx. Here are the lips. These are the upper lip, and below will be the lower lip. To the pharynx. Here is the oropharynx. Okay, one of the part of the pharynx you will study. Okay, so from the lip up to the oropharynx. Okay, so this whole thing is called as the mouth or as the oral cavity. So there is something called as the oropharyngeal isthmus. Okay, this opening is called as which connects the oral cavity with the oropharynx. This is called as the oropharyngeal isthmus opening, the junction between the mouth and the pharynx. So it extends, the oral cavity extends from the oral cavity from the lips up to the oropharyngeal isthmus. So this oral cavity is divided to two parts. One is called as the vestibule, okay, which lies between the teeth and the gums. So here are the teeth and the gums together internally and the lips outside. Okay, so between the lips and the teeth and the gum inside, there is a very small space. So only if you lift the lip, then you can see this small space. This small space is called as the vestibule. Vestibule between the lips and the gums and the teeth. Okay, this small space, when you lift the lip, then you can see the small space that is called as the vestibule. It receives the opening of the parotid duct. Why it is important? Because it receives the opening of the parotid duct. Parotid gland is one of the salivary gland which will open into this small space opposite the second molar tooth. Again, the second molar tooth, there is a small opening. Okay, there is a small opening. So that is just opposite to the upper second molar tooth. So just beside that, you can see a small opening that will be called as the opening of the parotid duct. So that's why this space is very important. If there is any blockage in the parotid duct, then you can trace it from here. Okay. The second is the larger space that is called as the oral cavity proper. So this is the oral cavity proper, this big space. Small space here, this is called a vestibule. The larger area of the oral cavity will be formed by the mouth cavity proper, lies within the alveolar arches, gums and the teeth. So between the teeth, gums and the alveolar arch, so all these are here. So this is the teeth, gums and the alveolar arch is the bone which is the deep inside. Inside whatever the space is there, this large space is called as the oral cavity proper or the mouth cavity proper. So it has a roof formed by the hard and the soft palate, as you can see again. So this is formed by the roof. This is the roof here, formed by the hard palate, as well as the this is called as the floor. Okay, which is formed by the tongue. This is the hard palate. Okay, so the roof is formed by the hard palate, as well as behind. If you go, you can trace even the soft palate. So again, going back to that picture, so this is the hard palate which is formed by the bone. Then there is a muscular part which is called as the soft palate. So this is the soft palate here behind, which is mainly muscular. The hard part is the bony part. So the roof is formed by both the hard and the soft palate. Then the floor is formed by the anterior two-thirds of the tongue. So here, this is the section showing you the roof here, and here is the tongue. Below is the tongue, which form the floor of the oral cavity. As you can see again here, this is the floor, this is the roof, and this is the floor of the oral cavity. Floor is formed by the anterior two-thirds of the tongue. Okay. It communicates with the vestibule behind the third molar tooth when you close your lips. Okay, so here this is the mouth cavity proper, or the oral cavity proper, and the vestibule is very small area. So this vestibule will communicate with the oral cavity behind the third, what is the third molar tooth. Behind the third molar tooth, there will be communication between the oral cavity proper and the vestibule. Okay, so this is the only communication. When the mouth is closed, there is no communication except from behind the third molar tooth. So here you can see the anterior two-thirds of the tongue, and the roof is formed by the hard palate, and here is the soft palate. The anterior two-thirds is forming the floor. The posterior one-third will be in the actually in the pharynx. Okay, oropharynx. We'll see later. So under the surface of the tongue, if you lift the tongue, what structures do you see? One is the central part of the tongue is attached to the floor of the oral cavity by a thin midline structure. This is called as the frenulum linguae. Linguae, the other name for the tongue. Lingula is the tongue. Okay, so this is the frenulum of the tongue, or it is also called as the frenulum linguae in the midline. It will present in the midline, which is connecting the lower part of the tongue with the floor of the oral cavity here. Okay, it connects the undersurface of the tongue to the floor of the mouth. Okay, the orifice of the submandibular duct opens on each side of the frenulum. Just beside the frenulum, so there will be orifice openings of the submandibular ducts on either side. Okay. Then the sublingual fold formed by the underlying sublingual salivary gland can also be seen here. If you see here, there is a sublingual fold underneath which will be the sublingual, very small sublingual gland. Okay, so all this can be seen. One is the frenulum, then the opening of the submandibular ducts on either side, submandibular gland, and the sublingual gland itself is elevated and it lies under surface of the this mucosa. Now coming to the palate. So here you can see here, this is the hard palate here. This is the hard palate. The palate from the roof of the mouth. It is divided to two parts, the hard palate as well as the soft palate. Hard palate, why it is called as hard palate? Because it is bony in nature, and soft palate is called as soft because it is muscular in nature. Okay. So coming to the hard palate, this is the hard palate. Okay. So here it is covered by the mucosa. If not, it will be mainly bony. This is how it looks like. The hard palate is formed by four bones. Which are those? The palatine process of the maxilla anteriorly and the horizontal plate of the palatine bones posteriorly. If you see here, this is the palatine process of the maxilla on either side. They are in pairs. Okay. So the palatine process of the right side and the left side. Okay. Then behind we have the horizontal plate of the palatine bone. The palatine bone has two parts, horizontal plate as well as the pyramidal process, but the horizontal plate will form the roof of the oral cavity or the hard palate. So hard palate is formed by the palatine process of the maxilla as well as the horizontal plate of the palatine bone. These are the two bones which are in pairs, so it becomes four bones. It is bounded laterally by the alveolar arch. Now here you can see here, this is the alveolar arch. This is nothing but the bony arch, okay, under into which the teeth will be inserted. So the sockets of the teeth will be within this alveolar arch. So this is the bony arch around. So it is bounded laterally by the alveolar arch of the maxilla. Behind it, it continues with the soft palate. If you see here, there is no soft palate right now here because only the bones have been shown. So this is the hard palate. Behind that here, the soft palate will be attached. Okay. It forms the floor of the nasal cavity. This is not only the roof of the oral cavity, but above that is the nose. So this also forms the floor of the nasal cavity. Now coming to the soft palate. So here it is the hard palate made up of bones. Now if it is covered by mucous membrane, this is how it looks like. This is the same hard palate. Behind that there is a muscular part. This is called as the soft palate. So soft palate, it is a mobile fold formed of bag of mucous membrane filled with striated muscles. So it is filled with, it is mainly muscular, made up of striated muscles. Striated means voluntary muscles. So, and it is covered by mucous membrane. So this is the mobile fold. Okay, the bony part is not mobile, but the, the muscular part is mobile. It is attached to the posterior border of the hard palate. As you saw, this is the hard palate. It is attached to the posterior border of the hard palate. Its free posterior border is conical projection called as the uvula. But the posterior part of the soft palate is free and it has a conical projection called as the uvula.
Doctor?
Yeah.
Doctor, I have one missing slide, which for the hard palette is not
Okay.
in the slide that's sent by,
Okay.
on the WhatsApp.
Okay. I will send it once again, or it is already on the Moodle. Okay. Check in the Moodle. Hmm. Moodle, there all the lectures are again attached. So
Yes,
check it. Okay.
thank you so much.
Okay. Coming to the muscles of the soft palate. Coming to the muscles of the soft palate, it is made up of 5 pairs of muscles. 5 pairs on either side. There are 5 and 5, so there are 5 pairs or 10 muscles. So which are those 5 pairs of muscle? One is called as the first one is called as the tensor palati, or it is also called as the tensor velli palatine. Okay, this is the muscle here. Then we have the levator palati, which is also called as the levator velli palatine. Then there is third muscle called as the palatoglossus. This is the long muscle here called as the palatoglossus. Then we have the fourth muscle which is called as the palatopharyngeus muscle. This is the palatopharyngeus muscle. And the fifth muscle is called as the musculus uvulae, which you already saw here. So this is the uvula made up of the musculus uvulae. Deep inside there is a muscle called as the musculus uvulae. These are the 5 pairs of muscles which will be forming the soft palate, and these 5 pairs or 10 muscles will form the actually the soft palate. Tensor palatini, levator palati, palatoglossus, palatopharyngeus, as well as the musculus uvulae. Now coming to the nerve supply of the soft palate. Okay. Now, what are the muscles which will, what are the nerves which will supply these muscles and how it will move? Okay. Coming to the motor muscles, which will help in the movement of the soft palate, all the muscles of the palate are supplied by the pharyngeal plexus of nerves. So all these muscles are supplied by the 5 pairs of muscles, except there is an exception, which is the tensor palatini. So except this tensor palatini, okay. So this is the tensor palatini or the tensor velli palatini. Except this muscle, all other muscles, the 4 pairs of muscles are supplied by the pharyngeal plexus, except the tensor palatini supplied by the mandibular nerve. Mandibular nerve. This is the tensor velli palatini, which is supplied by the mandibular nerve. All other muscles are supplied by the plexus of nerves called as the pharyngeal plexus. Pharyngeal plexus. Now, if you want to check whether these muscles are actually working properly, okay, so for that you can ask the patient to say ah. Okay, so the motor innervation of the soft palate can be tested by saying ah. Ask the patient to say ah. Normally, the soft palate rises upwards and the uvula moves backwards in the midline. Very important. The person says ah, so that the uvula will move in the midline and upwards. Okay, so it should be in the midline, not deviated to any side. So if it is deviated, then one side of the muscles have been injured. Okay, or the nerve supply has been damaged. Okay, so that's what it indicates. So it should, whenever the patient say ah, it should move upwards as well as in the midline, backwards, upwards, backwards, and in the midline. This is the motor testing of the muscles of the soft palate. All are supplied by the pharyngeal plexus except the tensor palatini, which is supplied by the mandibular nerve. Now coming to the sensory or the sensory supply of the soft palate. It is supplied by the maxillary nerve through the greater lesser palatine as well as the nasopalatine nerve. These are the maxillary nerve supplying the soft palate through the greater palatine, lesser palatine as well as the nasopalatine nerves, as well as by the glossopharyngeal nerve. These are the two nerves which will be supplying the maxillary nerve as well as the glossopharyngeal nerve. Coming to the movements. Okay, now whenever the patient say ah, it moves backwards, as I said before. So this is how it moves. Later I will show you the movements. Okay. Coming to the pharyngeal plexus, which supplies the soft palate. So the pharyngeal isthmus is a small opening here. This is the pharyngeal isthmus. It is the communication between the nasal and oral part of the pharynx. So this is the communication, just like there is oropharyngeal isthmus here, which is communicating between the oral cavity and the oropharynx here. Similarly, there is something called as the pharyngeal isthmus. This is pharyngeal isthmus. It is communicating between the nasal cavity and the oral part of the pharynx. That is called as the oropharynx. It is closed by raising the soft palate upwards. So whenever the person says ah, this soft palate will go and touches, and it closes this opening, pharyngeal isthmus. Whenever the patient say ah, and if you are asking the patient to say ah, and he will say this soft palate, if it is intact, no damage to any nerves or the muscles, then the soft palate will go and touches the wall, and this opening, this is the pharyngeal isthmus, will totally close. Okay. Closure occurs during the production of the explosive consonants in speech and during swallowing or saying whenever the patient says oh. Soft palate is raised by the contraction of the levator palatini as well as the palatopharyngeus muscle. So this is how it moves. So whenever the patient say ah, or he has explosive speech or swallowing, so this will go and closes the pharyngeal isthmus. At the same time, the posterior wall of the pharynx is also pulled forward. So this part of the pharynx, it is mainly bony, but still part of it slightly pulls forwards. The palatopharyngeal muscles on both the sides also contract so that the palatopharyngeal arch are pulled medially like the slide curtain. If you see here, so this here in under this deep part of this, there will be palatopharyngeus muscle, which will also contract and it will pull this opening. This is the oropharyngeal isthmus, which is communicating between the oral cavity and the oropharynx behind. Okay, so this also get pulled up and it pulls like a curtain and it comes down. Okay, the palatopharyngeus muscle, this is the palatopharyngeus muscle on both sides also contracts as the directions have been shown, so that the palatopharyngeal arch are pulled medially like a curtain. Okay, so here you can see here, this is the oropharyngeal isthmus. So so this part. Okay, this is the palatoglossus here, and deep inside will be the palatopharyngeus here. This is the palatoglossus, and this is the palatopharyngeus deep inside. So that will pull downwards, and it closes like a curtain. Now coming to the tongue part. Okay, tongue is a mass of the striated muscle. This is the tongue here, mass of striated muscles. Again, they are voluntary muscles covered by mucous membrane. Okay, its anterior two-third lies in the mouth and its posterior one-third lies in the pharynx. As you can see here, this is the whole tongue. So anterior two-thirds of the tongue lies in the oral cavity, but the posterior one-third lies in the pharynx, oropharynx. Okay, so this is the tongue. Anterior two-thirds in the oral cavity, posterior one-third in the pharynx. It is attached above to the styloid process, soft palate, and below to the mandible as well as the hyoid bone. So above it is attached to the styloid process, will be on the either side as well as the soft palate. Okay. Then below it is attached to the mandible. Here is the mandible. It is attached to the mandible as well as the hyoid bone. So deep inside here there is a bone called as the hyoid bone. Okay, where this bone gives attachment to the tongue muscles. Coming to the functions of the tongue, normally it helps in the normal articulation of the jaw. So whenever the tongue moves, it helps in the articulation of the jaw, manipulation of the food. Food will be twisted and turned within the oral cavity for better chewing as well as swallowing. Whenever the food is supposed to be swallowed, the tongue will go and get attached to the elevated and get attached to the roof or the palate, and the food is pushed in the form of a bolus into the oropharynx, and from there into the esophagus. The tongue is also very important for the taste, because the tongue will have a lot of taste buds, okay, which we'll study in the histology. The different types of taste buds will be present within the tongue, as well as tongue is also very important in speech. Okay, so these are some of the important functions of the tongue. One is the articulation of the jaw, then the manipulation of the food, swallowing, taste, as well as speech. So this is the structure of the tongue. So this is the structure of the tongue. So what are the muscles of the tongue? Which, because the tongue is mainly a muscular organ, there are no bones in that. Even though the muscles coming from that will be attached to some bones, but the tongue is free of any bone and it is completely made up of muscles. So what are the muscles of the tongue? The muscles of the tongue are divided into two types: intrinsic as well as extrinsic. So what do you mean by this? The intrinsic muscles are not attached to any bone. So they are free of attachment to any bone. Those muscles are called as intrinsic muscles, which are not attached to any bone. Okay. They consist of the longitudinal, transverse, and vertical fibers. If you see here, there are the superior longitudinal, inferior longitudinal, vertical, and transverse muscle fibers, which are free of any attachment to any bone. And these are the intrinsic muscles. Intrinsic muscles, they are the longitudinal. These are the longitudinal muscles in this direction, superior as well as inferior longitudinal. Then we have vertical muscles. Then we have the transverse muscles on either side. So these are called as the intrinsic muscles, which are not attached to any bone. So what is the function of these muscles? They help in the altering the shape of the tongue while it lies within the mouth cavity. So whenever the longitudinal muscle becomes short, the tongue becomes short. So whenever it wants to become long, then the muscles are pulled up. Okay. Similarly, the vertical and transverse, which will help in the thickening as well as the shortening of the tongue. So those are the intrinsic muscles. Okay. So vertical, transverse, as well as the longitudinal muscle fibers. Then coming to the extrinsic muscle fibers, which are the most important for the movement of the tongue. Extrinsic muscles of the tongue. Okay, which are those? One is, there are four pairs of muscles of the tongue. Okay, so which are those? These, as the name indicates, they are extrinsic muscles. They are all attached to the bone. That's why they are called as extrinsic. If they are not attached to any bone, they are called as intrinsic. Here they are all attached to the bones, so they are called as extrinsic. So attached to bone as well as the soft palate. So which are those four pairs of muscle? One is called as the palatoglossus. Palatoglossus. If you see here, so this is the palatoglossus muscle coming from the, as the name indicates, palato. The first name indicates the origin, second name indicates the insertion. So it is taking origin from the palate, soft palate, and goes into the glossus. Glossus means tongue. So that's why it is called as the palatoglossus. Then we have the second muscle called as the styloglossus, coming from the styloid process, going to the glossus, the tongue. The third is the genioglossus. Here is the genioglossus. Genial tubercles are there in the mandible. So here are the superior and inferior tubercles. From there, there is a muscle coming. So this is called as the genioglossus. And the fourth muscle is called as the hyoglossus, coming from the hyoid bone. If you see here, this is the hyoid bone, and the muscles coming from the hyoid bone. These are called as the hyoglossus. So these are four pairs. So they are present on both right and left side. So they are called as four pairs. Which are those? Once again, palatoglossus coming from the palate, styloglossus coming from the styloid process, genioglossus coming from the mandible, hyoglossus coming from the hyoid bone. These are the four pairs of extrinsic muscles of the tongue. Now coming to the nerve supply, all the muscles of the tongue are supplied by the hypoglossal nerve. So the hypoglossal nerve. So all muscles of the tongue are supplied by the hypoglossal nerve except the palatoglossus, except this muscle called the palatoglossus, which is supplied by the pharyngeal plexus. As you know, all the muscles of the palate except the tensor palatini All muscles of the palate are supplied by the pharyngeal plexus. So the palatoglossus is also supplied by the pharyngeal plexus. Except this muscle, all other muscles are supplied by the hypoglossal nerve. Now coming to the sensory innervation of the tongue. Very important is the sensory innervation of the tongue. Okay, so you should know thoroughly the whole of the tongue, especially coming to the motor and sensory nerve supply. Motor, as you know, as I said, it is supplied by all muscles are supplied by the hypoglossal nerve except the palatoglossus. Now coming to the sensory innervation of the tongue. Okay, coming to the sensory innervation, the tongue is divided, as we already saw, into anterior two-thirds and posterior one-third. Anterior two-thirds, which is present in the oral cavity, posterior one-third is present in the pharynx. Okay, so the anterior two-thirds of the tongue, which is present in the oral cavity, the general sensation of this tongue is by the lingual nerve. Okay, here all the motor and sensory nerve supply has been shown. Here on this side, it is the motor supply. All the muscles of the tongue are supplied by the hypoglossal nerve. Here, this is the hypoglossal nerve supplying. It is supplied on both the sides, but here they have shown the motor, and here this side they have shown the sensory supply. So hypoglossal nerve or the 12th cranial nerve. Okay, coming to the sensory nerve supply, the general sensation is supplied by the lingual nerve, anterior two-thirds by the lingual nerve. And the special sensation, the taste fibers are coming from the chorda tympani of the branch of the facial nerve. Okay, so the chorda tympanic branch of the facial nerve, it will be carrying the special sensation, that is the taste sensation. And general sensation, touch, pressure, and other general sensations are carried by the lingual nerve. Okay, so this is about the anterior two-third. What about the posterior one-third, which is present in the pharynx? Okay, so the posterior one-third, including the velli papillae. Okay, so there are valid papillae here. So, and the posterior one-third of the tongue, as well as the valid papillae, the general sensation is by the, as well as the even the special sensation, that is the taste sensation, are all carried by the glossopharyngeal nerve, glossopharyngeal, both for general as well as special sensation. Posterior one-third by the same nerve, glossopharyngeal, but anterior two-thirds, special sensation by the chorda tympani branch of facial nerve, and the general sensation by the lingual nerve. As you know, lingual means the tongue, so the nerve supplying the tongue will be the general sensation, will be the lingual nerve. Okay, then the roof of the tongue and the epiglottis. So behind that there is only a small, very small part, the roof of the tongue as well as epiglottis. The general and the taste sensation are carried by the vagus nerve, vagus nerve. So that is the nerve supply of the tongue. Now coming to the pharynx. Pharynx, behind the nasal cavity and the oral cavity, this part, this whole thing is called as the pharynx. It is a muscular tube extending from the base of the skull. So from the base of the skull behind the nasal cavity. Nasal cavity is also below the base of the tongue. So this is behind the nasal cavity. So this also starts from the base of the skull to the sixth cervical vertebra, up to the sixth cervical vertebra. This long muscular tube, this is called as the pharynx. This will continue below the sixth cervical vertebra as the esophagus. Below that, it will continue as the esophagus, below the sixth cervical vertebra. So it is funnel shaped with an upper expanded end and a narrow lower part. So if you see here, it looks like a funnel with a larger upper cavity compared to the lower part, which is narrow. Coming to the subdivisions of the pharynx, because it is a long tube, it is divided into three parts. It lies behind the nasal cavity, mouth, as well as the larynx. So depending on behind which cavity it is present, so it is named as it communicates with the nasal cavity, it will be called as the nasopharynx. So it is divided because it is behind the three important structures. So it is divided into three parts. Behind the nasal cavity, this is called as the nasopharynx. NP means nasopharynx. Behind the oral cavity, this is called as the oropharynx. With the oral cavity behind that, this is called as the oropharynx. behind the larynx. There's the larynx here, behind that this is called as the laryngopharynx. So there are three parts of the subdivisions of the pharynx: nasopharynx, oropharynx, and the laryngopharynx. If you see in this previous picture also, it is much more clear here. So this is the nasopharynx, oropharynx, and this is the laryngopharynx. Behind the larynx, this is the laryngopharynx. Behind the oral cavity, oropharynx, and behind the nasal cavity is the nasopharynx. Here you can see here, this is the nasopharynx. Behind the nasal cavity, behind the oral cavity, oropharynx, behind the larynx, laryngopharynx. This whole thing is the pharynx. Now coming to the muscles of the tongue, the muscles of the pharynx. There are three types. Actually, they are actually broadly classified into two types. One are called as the constrictor muscles, and the second muscles are called as the longitudinal muscles. Constrictor muscles as well as the longitudinal muscles. The constrictor muscles are three: superior, middle, as well as the inferior constrictors. And the longitudinal muscles are again three. Actually, there are three pairs on both the sides: superior constrictor, middle constrictor, and inferior constrictor. These are the constrictor muscles, and the longitudinal muscles are the salpingopharyngeus, palatopharyngeus, and the stylopharyngeus. Okay, so now you can see all these muscles one by one. So here you can see here, this is all the structures have been removed so that you can observe the three pairs of muscles. These are the constrictors. One is called as the superior constrictor. This is the superior constrictor. Then this is called as the middle constrictor, and this is the inferior constrictor. As the name indicates, constrictor, it helps in the constriction of the pharynx, superior, middle, as well as the inferior constrictor. So they are longitudinal, they are transversely placed. If you see here, they are transverse. The fibers are running almost transversely. Okay. Okay. Here now you can see here, this is the superior constrictor. This is the picture seen from behind. So picture from seen from behind, where it is totally closing the whole of the from posterior. This is the superior constrictor here. This is the middle constrictor, and this is the inferior constrictor. Posterior they are totally closed, but anterior they are open, opening into different cavities. Okay, so anterior it is deficient, but posterior it is totally closed. The three constrictor muscles overlap each other like the segments of an antenna. As you can see here, one muscle is overlapped by the other is overlapped by the third. So they are overlapping each other and they totally close the posterior surface. Okay. Each one fans out from its anterior attachment and passes posterior around the pharynx horizontal. As I said, they are almost horizontally placed and they totally close from behind. Coming to the longitudinal muscles now. You have already seen these are the constrictors, superior, middle, as well as the inferior constrictor here. This is the inferior constrictor. Okay, now coming to the longitudinal muscles. Which are those? One is called as the stylopharyngeus, coming from the styloid process. If you see here, this is the styloid process which is present in the base of the skull. From there is a muscle coming. This is called as the stylopharyngeus. Okay. Again here also the first name will be the origin and the second name will be the insertion. Stylo because it is coming from styloid process going to the pharynx, so it is called as the stylopharyngeus. Okay, here you can see here this is the stylopharyngeus. The second is the salpingopharyngeus. Salpingo means the eustachian tube or auditory tube. Okay, so there is a muscle coming from there. This is called as the salpingopharyngeus. Salpingopharyngeus, beginning from the of the eustachian tube and going into the pharynx. The third muscle is called as the palatopharyngeus. As the name indicates, it begins from the palate and goes into the pharynx. So this is called as the palatopharyngeus muscle. This is the third muscle. So stylopharyngeus, salpingopharyngeus, as well as the palatopharyngeus muscle. These are the three longitudinal pairs of muscles and three horizontal you have already seen: constrictor muscle, superior, middle, as well as the inferior constrictor. So these are the six pairs of muscles which are forming the pharynx. They are attached to the styloid process, as I said, auditory tube and the soft palate. Depending on that, they are named stylopharyngeus, salpingopharyngeus, and palatopharyngeus. What is the function of these longitudinal muscles? They elevate the larynx and pharynx and pull the palatopharyngeal arch medially during swallowing. So whenever there is swallowing, all these longitudinal muscles will pull it upwards as well as they help in the swallowing. Now coming to the nerve supply of these muscles. So as we saw, there are 6 pairs of muscles. Okay. So the motor supply for all these muscles is by the pharyngeal plexus, except the stylopharyngeus, which is supplied by the glossopharyngeal. So most of the muscles of the tongue or the pharynx, okay, all these the soft palate, they are supplied by the plexus of nerves, except the one, there will be always, there is one exception to each of them. Okay, so just like the soft palate, the palate here, the motor supply to all the muscles of the pharynx is by the pharyngeal plexus, except the stylopharyngeus, which is coming from the styloid process. It is supplied by the glossopharyngeal nerve. Coming to the sensory nerve supply, so there are 3 different areas supplied by 3 different nerves. Sensory, the nasopharynx is supplied by the maxillary nerve. This is the maxillary nerve, branch of the trigeminal nerve. Then the oropharynx is supplied by the glossopharyngeal nerve. Then the laryngopharynx is supplied by the vagus nerve. So this is the nasopharynx supplied by the one of the divisions of the trigeminal nerve, that is the maxillary nerve. Then the oropharynx supplied by the 9th cranial nerve, that is the glossopharyngeal nerve, and the laryngopharynx supplied by the 10th cranial nerve, that is the vagus nerve. So this is the sensory innervation, and motor innervation, as we have already said, it is supplied by the pharyngeal plexus, except the stylopharyngeus. Now, finally coming to the esophagus. Okay. So it is a long tubular structure, muscular structure, about 25 centimeters long. So it is long tube, muscular tube, beginning from the lower part of the pharynx. So it begins at the 6th cervical vertebra where the pharynx ends. So this will continue as the esophagus at the 6th cervical vertebra. It is long muscular tube, tubular structure, almost 25 centimeters long. And it pierces the diaphragm and enter this whole part. The initial part will be in the neck. This will be called a cervical. Then there is a thoracic part of this esophagus. Then it enters even the abdomen by piercing the diaphragm at the level of the 10th thoracic vertebra, and then enters the abdomen, a very short part that is called as the abdominal part of esophagus. Then it opens into the stomach. So the abdominal part is very short. So it has 3 parts: cervical, thoracic, and the abdominal part, because it is long tube formed of cervical, thoracic, as well as the abdominal part. So these are the 3 parts of the esophagus. Now coming to some important relations of the esophagus, because the esophagus is a muscular tube. Here you can see here, this is the section of the neck, showing you the esophagus. Behind are the vertebrae, and anteriorly we have the trachea and other structures. So because it is a muscular tube, it can be easily compressed. Okay, and in case of the carcinomas, how it will be affected? If there's adjacent carcinoma, how it will compress the esophagus, or if there is a carcinoma within the esophagus or the esophageal varices or other conditions, how do you approach the esophagus? For that, you should know the relations. Coming to the cervical part relations in the neck. So posteriorly, it will be in contact with the vertebral column. As you can see here, the vertebrae, cervical vertebra, just in front of that will be the esophagus. Laterally, we have some very important structures like the thyroid gland itself. If you can see here, is the thyroid gland on either side. It is covering even the esophagus. So anteriorly, we have the trachea. So there is the trachea with the tracheal tubes and the trachealis muscle behind that. Okay. The trachea and the recurrent laryngeal nerve. Just beside that, there will be the recurrent laryngeal nerve, right, as well as the left recurrent laryngeal. Very important nerves which are beside the esophagus. Okay. So here you can see here the trachea. Just behind that will be the esophagus. This is the esophagus completely running in the superior mediastinum in the neck, and the superior mediastinum, then the posterior mediastinum entering into the abdomen. In the thoracic part, it passes downwards and to the left through the superior as well as the posterior mediastinum. After from the neck it begins, then it enters the superior mediastinum of the thorax and then enters the posterior, because it is going behind the heart, so it should be the posterior mediastinum. At the level of the sternal angle, the aortic arch and the left bronchus push the esophagus again to the midline. It will be deviated towards the left side, then at the sternal angle, it comes back to the midline. So here you can see here, this is the esophagus, trachea is in the front, these are the tracheal rings, and behind that is the esophagus, and here is the recurrent laryngeal left, and here will be the right. Okay, so it is running behind the esophagus, the trachea. Then here you can see here the arching of the aorta. Okay, the tracheal bifurcation as well as the arching of the aorta. Okay, and here is the esophagus running downwards. Coming to the anterior relations of the esophagus in case of the thoracic part, anteriorly as we know, we have the trachea in the upper part and the left recurrent laryngeal. This is the left and this is the right recurrent laryngeal nerve, this is the left recurrent laryngeal nerve. The left principal bronchus, so here you can see here this is the left principal bronchus, because the left principal bronchus is longer in size, so that is also in relation. Then the pericardium of the heart. In front, we have the heart. In the lower part, especially in the thoracic part, we have the heart as we saw before. So, okay, so here you can see here, the heart is in the front. Okay, this is the esophagus, and in front of that, the heart and the pericardium. The covering of the heart will be present. Then, the left atrium. Here also you can see here. So these are the vertebrae here, and here is the heart, and this is the trachea here, and behind that is the esophagus running all the way into the diaphragm. So this is the diaphragm here, esophagus into the front. We have the heart and the pericardium. Behind we have the vertebrae, and these are the intercostal spaces. Coming to the posterior relations of the thoracic part of the esophagus. One is the bodies of the thoracic vertebra. All these bodies of the thoracic vertebra are in relation to this is the esophagus, cut so that you can appreciate the structures which are behind. Then the thoracic duct, this green structure, this is the thoracic duct, which is also posteriorly present. Then the azygous vein, this is the azygous vein. Then we have the right posterior intercostal veins. So these are the right posterior intercostal veins. Then the descending thoracic aorta at the lower end. So then behind there will be descending thoracic aorta. If you go to the previous picture, if you can see here you can see here, this is the descending thoracic, this is the arch of aorta, and the descending thoracic aorta also go behind the esophagus. So here you can see again, this is the esophagus, and here with the esophagus behind that is the descending thoracic. This is the arch of aorta and its branches, and here is the descending thoracic aorta going behind in posterior relation to the esophagus. Okay. Coming to the lateral relations, what are structures which are on the right and left side? On the right side, we have the right mediastinal pleura. So right side, we have the right lung and the right mediastinal pleura. The terminal part of the azygous vein, here you can see the azygous, we already saw the azygous vein here. This is the azygous vein, which also with its terminal part. Okay. Then on the left side, we have the left mediastinal pleura. Then the left subclavian artery. So here, this is the subclavian artery here. Okay. If you can see here, this is the left subclavian artery, this one, which is supplying the left upper limb. Then the aortic arch, this is the aortic arch. Then the thoracic duct. We already saw the thoracic duct, which come on the left side. Now coming to some clinical aspects related clinically, esophagus and the left atrium of the heart, how it is important. Okay. More of this you will study later when you go to the clinical side, but here we will just briefly introduce you to some of the important questions. There is a close relationship between the left atrium of the heart and the esophagus. Okay. So what is the clinical importance? A barium swallow in the esophagus will help the physician to assess the size of the left atrium. If you see here, the person has swallowed the barium swallow, so the barium is entering. If not, you cannot see the esophagus. So once the person take the barium swallow, it will enter through the esophagus. Okay, so it will assess the size of the left atrium, the dilatation, as in case of the heart failure or long-standing mitral stenosis. So if there is any compression of this esophagus, as you can see here, so this will be because of the dilatation of the left atrium, maybe because of the heart failure or the long-standing mitral stenosis. In the abdomen, the esophagus is very short, as we said. Once it enters the diaphragm in the abdomen, the abdominal part of the esophagus is very short before it opens into the stomach. In the abdomen, the esophagus descends for 1.3 centimeters and joins the stomach. It is very short, just 1.3 centimeters. Anteriorly, it is related to the left lobe of the liver. So as you can see here, this is the liver, this is the right lobe, this is the left lobe. So anteriorly, it is related to the left lobe of the liver. So only when you lift it, you can see the esophagus. Posteriorly, it is related to the left crust of the diaphragm. Here you can see here is the esophagus, the left crust. This is called as the left crust of the diaphragm. This is the diaphragm. This is the scene from below. From the abdominal cavity, you are seeing the diaphragm, and here is the esophagus. This is the inferior vena cava. There are two crusts, right crust, and here is the left crust of the diaphragm. So the left crust of the diaphragm will be in posterior relation to the esophagus. Fibers from the right crust of the diaphragm form a sling around the esophagus. If you see here, the fibers from the right crust also form a sling around the esophagus. Okay. At the opening of the diaphragm, the esophagus is accompanied by the two vagi. So there are two vagi, the right and the left vagus will be on either side. Not shown in this picture, but it will have the vagus nerve. Branches of the left gastric artery vessels. Okay, those arteries and the veins will be around this, which will supply the esophagus also, as well as drain the esophagus, the veins. Then also we can see the lymphatic vessels. All those are there, but not shown in this picture. Coming to the esophageal constrictions, there are the pathological constrictions as well as the normal constriction. So you should be able to differentiate between pathological and normal constriction. For that, you should know first the normal constriction. So only when you know the normal constriction, anything apart from that will be called as the abnormal constriction. So what are the normal esophageal constriction and why they are present? There are three anatomical constrictions. The first is at the junction with the pharynx. Whenever the esophagus begins from the pharynx at the sixth cervical vertebra, there is constriction. So that is called as the pharyngoesophageal constriction. So almost 16 centimeters from the incisor teeth, from the oral cavity. Why it is important? Because whenever you passing a Rile's tube, any tube from the oral cavity, there will be always measurements. So if you approach any constriction at the level after 16 centimeter, then it is because of the pharyngoesophageal junction. Okay, constriction. Then the second is at the crossing with the aortic arch. So whenever the aortic arch crosses the esophagus, there will be second constriction. This is called as the thoracic constriction, or it is also called as the aortobronchial constriction, because the bronchus is also crossing the esophagus. So this is almost 23 centimeters from the incisor teeth. All these measurements are from the incisor teeth. Then the third is at the junction with the stomach. So whenever it opens into the stomach or whenever it enters the diaphragm. Okay, some take the constriction at the entry of the diaphragm as the constriction. Some take it at the entry of into the stomach. Okay, so this at the diaphragm, this is called as the esophageal sphincter. It acts as a sphincter, diaphragmatic constriction or esophageal constriction. Okay. So this is almost 38 to 40 centimeters from the incisor tip. These are the three normal constrictions. Okay. So if you face any constriction at this level, during this barium swallow, if you see the constriction at this level, or if you are passing a tube and you feel difficulty in passing at this level, then this is because of the normal constriction. So these constrictions have clinical importance. As I said, whenever there are abnormal constriction, you should be able to differentiate. So the esophageal strictures or constriction, they may cause difficulty passing an esophagoscopy. So when you're passing a Rayleigh tube or the esophagoscope, especially esophagoscope is much larger and it is metallic. So whenever you're passing a tube, esophagoscope is the scope with which we can see observe the esophagus. Okay, so you see the internal part of esophagus, you pass a tube called as the esophagoscopy. So whenever you pass esophagoscope, so and the process is called as esophagoscopy. So whenever you pass the tube, then you feel constriction at this level, difficulty in passing this esophagoscope. In case of swallowing of the caustic liquids, mostly in children, the acidic type of liquids, this is where the burning is the worst and strictures develop. So these are the three areas where there will be more of the burning if there is any accidental drinking of the acids. Okay, and there will be constriction strictures, abnormal structure at this level. The third is the esophageal structures are more common place of the development of the esophageal carcinoma. These are also the regions where there will be regular frictions because of the food particles which can lead to esophageal carcinoma. In the same three regions. So in this picture, so the importance of the scale I have already told you. Okay, because whenever you're passing a tube, you should be able to know that this is the normal constrictions where these structures are present. Okay. Now coming to the arterial supply, blood supply of this esophagus. So the upper third is, because it is long tube, it is supplied by different arteries at different levels. In the neck, it is supplied by the inferior thyroid artery, as in the picture here. Okay. In the middle third, it will be by the thoracic artery, the thoracic aorta, which will be giving the esophageal branches, multiple branches, many branches. And in case of the abdomen, it will be supplied by the left gastric artery. So these are the three arteries which will supply the esophagus. Coming to the venous drainage is very important because it leads to a condition called as the esophageal varices. Okay, so the upper third is drained by the inferior thyroid vein, middle third by the azygous vein, so azygous as well as the hemiazygous vein, which are around the esophagus. In the upper third in the neck, it will be inferior thyroid vein, and in the lower third, it will be the gastric vein, which is the site of portal vein, portocaval anastomosis, which leads to esophageal varices. Now coming to the lymphatic drainage, again it is divided into upper, middle, and inferior. The upper third in the neck, it will be drained into the deep cervical group of lymph nodes in the neck. In the middle third, it will be draining into the superior and inferior mediastinal lymph nodes. Okay, and in the lower third, it will be draining into the abdomen in the cilia group of lymph nodes. So this is all about this lecture, which includes the oral cavity, the pharynx, as well as the esophagus. So if you have any doubts regarding this, you can ask me.
Doctor, can you send the update lecture? Because not
Yeah.
as the model.
Okay. Even in the model, it is different.
Yes.
Okay. Then I will send you. Okay.
Okay, doctor, nerve supply of esophagus, is it with us?
Okay. Mentioned here in this lecture. Okay. Anyhow, no problem. You can just have it, whatever is there on the slides. The remaining part will just forget about it. Okay. Okay. Anything else?
Thank you.
Okay. Thank you very much. Thank you.